Hi, everybody. My name's Ashley Vance. I know I've met a few of you a couple weeks ago in Skills Lab. I'm doing the nurse educator courses through UNMC as well as my family nurse practitioner and will be graduating in May. As part of the nurse educator courses, I am doing some clinical practicum hours to complete those courses. So Stacy's helping me out with that. And I'm helping her out this week with fluid and electrolytes. So I'll be bringing you IV fluid therapy so we can kind of discuss a little bit more about how we can use IV fluids to help with our fluid and electrolyte balances. So the objectives I want you guys to make sure you're able to know after this piece is to understand the different types of IV fluids, the reason for using each type, the potential complications of fluid therapy in general, and identifying the different types of IV access. You will be practicing peripheral access this week, but I will also touch on central lines. We won't be doing anything with them, but just so you guys are more familiar and aware of what to do with them. And then identify the steps in the procedure of obtaining IV access, which you'll be working on in Skills Lab again this week. So IV fluids, why are we using them in general? I know the majority of your patients that you've probably seen in the hospital are on some kind of IV fluids for some reason or another. Fluids are used to treat many different fluid and electrolyte imbalances. Say you have a patient that comes in with a fluid volume deficit and they're hypernatremic. We're able to give them fluids along with doing a few other interventions to hopefully correct that. We're also able to give fluids for use of maintenance fluids, our everyday fluid requirements. Some patients are unable to take PO fluids. Either they're too sick to take the fluids or they're a surgical candidate and they're NPO. So this is a way we can give them the fluid just for meeting basic requirements that way. Also, we can do it for replacement of losses. So we have a patient that comes in, again, fluid volume deficit. We're able to replete their volume just using the IV fluids and hopefully pushing PO fluids as well. So I just want you guys to kind of keep in the back of your mind what are the necessary daily requirements for patients that are just receiving the maintenance IV fluids. How do we determine what type of fluid we give our patients? Well, it's dependent on requirements for your specific patient. So every patient comes into the hospital for a little bit different reason. So depending on whether they're fluid volume deficit, whether they have some kind of electrolyte imbalance, depends on the type of fluid we're going to give our patient. Of course, our doctor is going to be the one determining the type of fluid, but this way you know the reason why. Tonicity also plays a factor in determining this. Tonicity is the concentration of particular electrolytes in the fluid compared to blood plasma. So always keep that in mind. It's the type of fluid compared to blood plasma. Okay, we'll kind of break these down here in just a second. So our three different tonicities that we do have available are hypotonic, isotonic, and hypertonic. Hypotonic is that there are more water than electrolytes. Again, this is against blood plasma. So we have more water than we do electrolytes. So the inside of the body of the patient basically has more electrolytes than water, and we want to correct that. Isotonic, similar concentrations of water and electrolytes. So we're going to have kind of osmosis both directions equally. And then hypertonic, we have more electrolytes than water. So say they're hyponatremic, and we need to correct this. We'll talk about this a little more in each slides. So let's talk about hypotonic. A hypotonic solution has more water, than electrolytes, like we talked about before. A hypotonic solution dilutes the extracellular fluid, which lowers the serum osmolality. So when it lowers this, osmosis then produces a movement of water from the outside the extracellular space to the interstitial space or the intracellular fluid, causing cells to swell. So let's talk about this a little bit more. So here's a little picture. Here's a cell. Notice how it has 20% water inside. Our solution that we give is hypotonic, so it has less electrolytes, but it has more water. So because of the osmolality gradient, it's going to make water move into the cell. It wants to dilute this more to equal what our dilution is on the outside. So once we have all this water moving in, this cell that was regular shaped before now will swell because it has extra water in it. So we kind of want to keep that in mind as we get to our interventions. Our cells are swelling. What do we kind of need to be looking for as nurses? An example of this is half normal saline. So hypotonic patients. What type of patient will benefit from a hypotonic solution? Is it a patient that would benefit from a diluted extracellular fluid space? Which electrolyte would we maybe want to draw out, especially with like half normal saline? Probably sodium. There's sodium in half normal of the sodium and the half normal sodium. So a patient with hypernatremia would benefit from a hypertonic solution. So they have lots of sodium within their cells, and we want to dilute that out basically. So we're going to give them hypotonic, more water than electrolytes. The water's going to go in and hopefully dilute out the sodium that's within the cells and normalize that electrolyte reading. So actually, half normal saline is a good maintenance fluid as well, because normal daily losses are actually hypotonic. So, through sweating, through our urine, through stools, all of that. So keep that in mind. Hypotonic is not a good replacement fluid. Again, it's a good maintenance, so for everyday life, but not a good replacement fluid if somebody comes in with a fluid volume deficit, because it depletes that extracellular fluid volume. All of that water moves in and doesn't maintain in circulation. Some potential complications we need to look for as nurses: it may lower our blood pressure because we're depleting that extracellular fluid. It may cause that cellular swelling, which may lead to edema in very many different places, especially within the brain. So we want to make sure we're checking mental status changes because it can lead to cerebral edema. Nursing interventions we need to be aware of for hypotonic solutions. Make sure we monitor our vital signs, especially the blood pressure, because it can make it hypo. It can make your blood pressure drop. You can also monitor accurate I's and O's. Monitor your neurostatus and make sure we're monitoring our labs if that is something that we're trying to correct. Next, let's move on to isotonic. So isotonic fluid is has the same amount of fluid and electrolytes as inside the cell. So because the extracellular fluid and the intracellular fluid are similar, fluid stays within the extracellular space. It doesn't need to go across the gradient into the cell. So this expands the extracellular fluid volume. So a good example of this is normal saline or even lactated ringers. So here you can see you have the same amount, the same concentration of your electrolyte inside and outside. So water is free to move in and out. It's equal on both sides. So if we need to increase the extracellular fluid space because of patient's fluid volume deficit, this would be a good one to pick. So what type of patient would benefit from an isotonic solution? Where does the fluid stay at? What did we just talk about? That's right, a patient with fluid volume deficit would be a very appropriate patient to receive this fluid. They come in, they're volume depleted, they just need a little extra help. So we're able to give this fluid and increase that extracellular fluid so they're able to maintain regular body functions. It's also a fluid of choice for replacement of volume. I'm sure you've seen this is probably the number one use in the hospitals. You can also use LR. It's used more for patients like in surgery, burns, if they have any GI fluid or losses. The electrolytes that are within the LR are just a little bit different than the normal saline. Some potential complications we need to be aware of for isotonic solutions if we give that fluid overload. We're obviously increasing the extracellular space, and we can excessively hydrate these patients. So We need to be very cognizant of our patients with cardiac and renal disease, especially those like with CHF, or any kind of renal disease where they're not able to excrete the appropriate amount of fluid out. So some nursing interventions I want you guys to be aware of: monitoring your vital signs, doing accurate I's and O's. Obviously, if a patient came in with fluid volume deficit, they're low, so we want to make sure we increase their intake. Sorry about that. Also want to monitor their cardiac status. Monitor their lung sounds. If they're getting too crackly, we're probably giving them too much fluid and causing some pulmonary edema. Monitoring their peripheral edema, and possibly other CHF indicators, especially if they have a history of the CHF. We don't want to exacerbate that at all just by giving them extra fluids. We also want to monitor our labs. We won't necessarily dilute out electrolytes, but we may dilute out their hemoglobin hematocrit. We just want to keep an eye on all of the electrolytes as well. Moving on to a hypertonic solution. So this raises the osmolality of this extracellular fluid. So it expands volume. The higher osmotic pressure on the outside of the cell draws water out of the cell into the extracellular fluid. So let's see, here we go. So here's our cell again. Notice how it has a lower concentration of sodium in the extracellular space. So because our sodium's higher on the outside, we're going to move water out. That's going to that's going to expand our volume again. Patients that this helps with is our hyponatremic patients. So, hypernatremic patients, because we're drawing the water out. Examples of this are 3% normal saline, our D5 in NS, and D10 in water. So what type of patients, like we just talked about, will benefit from hypertonic solution? Which way does the water go, out or into the cell? Where's the gradient the highest? What does this do to electrolyte concentrations in the cell? So we want to dilute the electrolytes. That's right, a patient with hyponatremia. So, and I might have said this wrong in the slide before, and I apologize. It is a hyponatremic patient. We want to give them an increased amount of electrolytes so we can move the sodium appropriately so the patient normalizes out their balances. Patient with head injuries are also benefiting from this type of therapy, especially when given with diuretics, because the water is moving out of the cell into the extracellular fluid space. So it's kind of shrinking those sites and decreasing the pressure in the head. And it's really great when it's given with diuretics because the patient is able just to pee all of that fluid out, so it's not remaining in circulation. Potential complications we need to look for hypertonic solutions. The fluid volume overload, obviously, because we're increasing the extracellular space, and then hypernatremia as well, because we're giving a hypertonic solution. We can make too much sodium. Nursing interventions, I want you guys to be aware of monitoring your vital signs, especially the blood pressure. Again, we're increasing the extracellular space. Accurate I's and O's. Monitoring your neurostatus is very important. Monitoring lung sounds, again, we're increasing the fluid volume. And then monitoring labs. IV fluid additives can also be used. So this would be just one of those, usually it's like normal saline, D5LR, half normal, just depending on what our patient needs. But specific electrolytes can be added to them to help with correcting those specific electrolyte imbalances. So common additives, potassium chloride, I'm sure you've probably seen before, calcium chloride, magnesium we can add, and we can also add some bicarb, just dependent on, a lot of that is like more acid base. Common crystalloids that we use with their tonicities can be seen in 16-17 table in Lewis.